Hi there, it's Debbie Clark. I'm just going to talk to you about the next section of recognising and managing a patient with an acute kidney injury. I'm hoping by now you've undertaken the pre-sessional work and reviewed some of the anatomy and physiology of the kidney and are feeling fairly confident about the roles the kidney play in the body and the important functions that it does. And we're going to move on and have a little look at what acute kidney injury actually is and what it looks like, how you'll spot it and how you'll manage it. Okay, so let's have a little think about what acute kidney injury is and what it looks like. It doesn't really matter where you're working within a secondary care setting, you are likely to come across patients who are suffering from acute kidney injuries, whether that's in a medical ward or whether it's in a surgical ward, geriatrics, high dependency. You'll find this wherever you're working really within secondary care. So the term acute kidney injury is now the universal term that is used to describe a sudden deterioration in kidney function or renal function. And it actually replaces a term known as acute renal failure. So you may have heard that both of those terms being used when you've been in practice. Some people do still talk about acute renal failure, but acute kidney injury is the new and certainly the preferred term, and hopefully that's what you hear the majority of the time. The reason for the shift over to acute kidney injury is really to sort of grab attention, and when we think about an injury, we think about something that doesn't possibly have to happen. It is something that has occurred and we don't really want it to be there. Whereas acute renal failure just suggests that the kidneys have stopped working. And although it's got the word acute there, suggesting it's sudden, it doesn't really suggest there was anything we could It doesn't really suggest there's anything we could do to prevent it. So, the term acute kidney injury is designed to grab attention, and it's designed to make us realise, or as healthcare professionals, that we can do something about this, that it is avoidable and it is preventable. So that is the first thing. Acute kidney injury is different to chronic kidney failure. So a chronic condition is one that lasts several weeks or months. And it will probably stay with the patient, in fact normally does stay with the patient, whereas an acute condition comes on rapidly over a few days to weeks, and that is the difference there. With kidney failure, we can also have a situation when sometimes we get an acute kidney injury on top of chronic failure. So a patient could be suffering from long-term chronic kidney problems and then have to go for surgery. They become dehydrated through surgery or due to blood loss or something, and can have an acute injury on top of their chronic condition, and that would be called acute on chronic kidney injury. So AKI, or acute kidney injury, is detected by two measures. One is measuring the blood creatinine level, and secondly by measuring the patient's urine output. And you've probably seen and heard of both of those things being done if we start to think a patient might be suffering from acute kidney injury. The other thing we know is that acute kidney injury is really a common condition, and as I said at the beginning, it can crop up in any setting really. We also know that it affects patients' mortality significantly. So if a patient acquires an acute kidney injury, they are more likely to die. And with that, they're more likely to have a longer length of stay in an acute setting, which is obviously undesirable for most patients. Okay, let's move on. So, why did we get interested in acute kidney injury really? Well, in 2009, a national confidential inquiry into patient outcome and death found that 15% of AKI cases were avoidable, and they made some recommendations based upon that. Now, every year, the National Confidential Inquiry into Patient Outcome and Death publish reports onto things where they feel care, or where there's evidence really that care could be improved. And in 2009, AKI was one of the areas we were encouraged to focus upon. And since this time, you will have seen many things change in practice. So if you've been working in secondary care for some time before starting your nurse training, you might have noticed a change in the way things were done. A lot more attention was given to acute kidney injury. Most trusts have got special educators who are trying to roll this training that you're having now throughout the workforce to make sure people know how to recognise an acute kidney injury as it's occurring and know what to do when they do spot it. This report also detailed that all NHS trusts should have a policy for the management of acute kidney injury, and now you will find that in all the different trusts where you work. It also suggested that all acute admissions should receive a senior review within 12 hours of the patient being admitted, and that should be via a consultant. It also raised the issue and highlighted that predictable and avoidable acute kidney injuries should never occur, and again just reiterated really that they are avoidable. So maybe next time you're out on practice, try and have a look around for things that you can see that are supporting the implementation of this policy. We often talk to you in uni, don't we, about policies and how they are used or demonstrated in practice can be a bit different. But if you look about, I think you will see things that support this policy. Things such as when you go and look at blood results on the computer, often there's a little pop-up that is linking blood results through to a prompt to check for AKI if there's something on those bloods that is a bit concerning. So that was something, for example, that came out of this piece of work. So risk factors for an acute kidney injury and some common insults. We'll come on to that side in a moment. So if we start over on the risk factor side of this slide, you can see there are quite a few things that you can be thinking about even when you're admitting a patient or your first contact with them that can make you think in your head, is this patient at risk of an acute kidney injury? So firstly, we need to a risk factor would be age. If the patient is over the age of 65, they are at risk of having an acute kidney injury. Secondly, any patients with heart failure, liver disease or diabetes are higher risk from experiencing an acute kidney injury. So, people with heart failure could be at risk of an acute kidney injury because the pump of the heart is poor and it's not perfusing the kidney adequately with an oxygen-rich blood supply. And we know that the kidney really likes a good blood pressure. So if blood pressure falls, the kidney goes to sleep and won't function. So it's probably easy to see how somebody with a degree of heart failure could have an impact upon their kidneys. If you think about the deteriorating patient, for example, sometimes if you see blood pressure drop, you'll see urine output drop off, and that is an illustration maybe of that. In liver disease, so people with chronic liver conditions put an increased demand upon their kidneys to function and to eliminate waste products. So anyone with a liver disease is at risk of an acute kidney injury. And the same with diabetes. So if you think about the damage that diabetes can do to, let's say your eyes with retinopathies, or to limbs and digits with neuropathies, those sugar molecules damaging those tiny little blood vessels can be really problematic. And that same disease process happens within the kidney and damages the very delicate structures within the kidney, making, again, that more of a problem and making the patient more at risk of an AKI. So I mentioned previously that you can have a chronic kidney condition, a chronic disease, and you can have an acute kidney injury on top. In fact, you're more likely to have an acute kidney injury if you are suffering from a chronic kidney condition. You don't really need to worry about the estimated glomerular filtration rate. That is a calculation that's done that looks at the functioning of the kidney and how effective it's being at clearing waste products. But sufficient to say, if somebody has a chronic kidney condition, an acute injury is more likely on top. Following that then, if you've already had an acute kidney injury in the past, you're possibly more likely to have one in the future. So if you are getting handover and somebody tells you the patient's had an acute kidney injury, or they're admitted to their ward with acute kidney injury, things seem better, be looking out for it coming back. And finally, on the risk factor side is people with multiple myeloma, so blood cancers, and the large molecules involved in those tumours can damage the kidney structure. So we have got some risk factors that make it more likely or less likely that somebody might acquire an acute kidney injury. Then we have got things that happen that make that even more likely again. So common insults. Hypertension is the big one, and I sort of mentioned a scenario there a little while ago that if a patient went to theatre and their blood pressure dropped because they lost some blood, the kidneys are very sensitive to that and they may stop working if that isn't treated promptly. So it says in brackets absolute and relative. So that is referring to the blood pressure drop being related to them as a person. So if a person normally has a normal blood pressure is say 120/80, but if somebody has a blood pressure of 150/90 and it drops to 120/80, that could still be hypertension. So that's what we're talking about there, that it wouldn't be on a chart or a scoring system, it might not flag up, but it could still be a significant or a relative drop in blood pressure for them, and that could impact on the kidneys. Sepsis is an insult that can make an AKI more common. So if we're treating patients with sepsis, we monitor urine output and we consider giving fluids to raise the blood pressure and ensure we're providing adequate perfusion. When we send patients for CT, sometimes we use contrast with the scan, and contrast can be very damaging to the kidneys. So that can be an insult. If somebody was borderline beforehand and then we give them contrast for a scan, there is a possibility we would push them over the edge and tip them into an AKI. And then there are other drugs which are nephrotoxic and can actually cause damage to the kidney. And actually there's loads of drugs that do this, and they are really common. You need to look out for this on drug charts, because actually if you start to identify a patient's urine outputs dropping, and you may think about giving the patient fluids or getting some keeping an eye on the urine output, what we can be less good at is reviewing the medications that patient's taking, which will be building up in the system and possibly causing further damage to the kidneys. If you look in the BNF, whether online or in the book, you will see that doses get reduced in renal impairment or in acute kidney injury. So you can use that as a guide, and certainly at your stage, as third year student nurses, you need to be prompting doctors if they're not reducing medications when they're seeing an AKI. So drugs to watch out for are things like non-steroidal anti-inflammatory drugs, aminoglycosides, antibiotics, so gentamicin, vancomycin, that kind of family. And then there's the ACE inhibitors, ramipril, that can particularly be a problem. Drugs such as ranitidine can cause a problem. And at the bottom it says there diuretic therapy. So furosemide, which we sometimes would give if people were overloaded with fluid and weren't passing urine, can actually make the situation worse. So it's really important we do not overuse furosemide, because it might make us feel better in that we see some urine output coming, but normally it is detrimental, and a couple of days down the line we've made the situation worse. Okay, let's move on. So, causes of acute kidney injury. It is worth bearing this in mind. You don't need to be an expert of this, but I think it is worth just thinking about where the problem is. And there's three main causes of an acute kidney injury. There's the pre-renal causes, which are over on the right-hand side of your screen. There's the intrinsic, so things going on actually was inside the kidney that can cause problems. And there are things external to the kidney after the urine's been produced. And we'll just have a quick whip round this slide just to make sure you've got these in your head. I think it's useful to bear this in mind, because you sort of, by thinking this way, you're starting to think about treatments and what the problems are and what you can do about them. So, pre-renal causes. sepsis and hypovolemia are two of the main causes. Sepsis and hypovolemia will lead to a drop in blood pressure. That in turn will lead to poor perfusion of the kidney, and the kidney will be upset by having reduced oxygen-rich blood supply. So we can do things about that, because before even we've got to the kidney, we can start optimizing the patient. So often we would use fluids to replace any fluid losses from the low circulating volume. We could even use blood transfusions if that was required. So in the classroom, when we're stood here or when we're sat here talking about this kind of thing, you go, yeah, okay, that's really great. If I recognise someone was hypovolemic, of course I'd give them fluids. But sometimes in practice, it's really hard to get a view, isn't it, of fluid losses and fluid intake. So I'm sure you've all looked at the lovely fluid balance charts in your career and gone, these don't make very much sense to me, or maybe you don't. Maybe they do make a lot of sense and they've been well maintained. But generally, the thought is that fluid balances could be filled in more accurately. Doctors find it really hard if they're asked to come and review a patient at 2 o'clock in the morning and they've got the previous few days' fluid balance charts and they're inaccurate in terms of understanding what's gone in and what's gone out. So I suppose that's a bit of a plea to try and make sure we think about that. And probably better to have less patients on fluid balance charts, but the ones that are, make sure we're doing it really properly and really fastidiously. Okay, so other pre-renal causes can be hepatorenal syndrome. So that's the interaction with the liver and the kidney, and when that's occurring, that the pressures in the liver can put additional work upon the kidney, which causes problems. We mentioned cardiac failure a little bit earlier on. So if the heart pump isn't working, again, we're going to struggle to get that oxygen-rich blood supply to the kidney, and it won't like that. And then the final one is hypertension, which we have mentioned, but hypertension can be caused through medications that we give. So sometimes we will carry on giving patients normal antihypertensive medication when they don't need it, and that can be very damaging to the kidney. So making sure that if the patient's got a low blood pressure, we aren't adding insult to injury by giving any drugs that will make that problem even worse. So, pre-renal causes are really in your gift to be able to sort out. They're probably the easiest ones to turn around and make an improvement to the patient. And those patients should certainly not be having prolonged periods with low urine output, and we should be able to do something about those situations. So, intrinsic AKI. Here we're talking about actual damage within the unit of the kidney itself. So, under acute tubular injury, we have got a few different things coming up there. The first one is prolonged renal AKI. So, if you are in a pre-renal AKI phase for a long time, let's say you've got sepsis, you're given some fluid but your blood pressure doesn't pick up, and if that goes on for a long time, you will actually get tubular damage within the kidney, which is obviously not something we want to happen. The second one, we've got rhabdomyolysis. So we're thinking there about the proteins that are broken down and can block up the kidney. And rhabdomyolysis classically occurs if somebody falls and if they've been laid in one position, I'm going to say on the floor, but I suppose they could be somebody stuck in one position for a very long time. The muscles break down and those big protein molecules within the muscles block up the kidneys. Okay, we've got hemoglobinuria, which is the blood molecules, again causing blockages within the kidney unit. We've got nephrotoxins being used. We mentioned before about non-steroidals, for example, that can cause actual damage to the nephrons themselves. Things like glomerulonephritis, so inflammation of the glomerulus. Myelomas, so things like cancers, blood cancers that cause blockages, and then vasculitis. There are lots of different types of vasculitis, but again, inflammation of the vascular tissue within the unit of the kidney. Post-renal causes, finally, are the things that are happening outside of the kidney. So, we can imagine in this scenario that pre-renally, blood pressure's fine, the patient's not got any risk factors going on there. Intrinsically, no problem either. The kidney unit is working well. But post-renally, there is some kind of problem. And quite often with post-renal, it's to do with a mechanical blockage. And you can see it says here things like kidney stones, tumours, or enlarged prostate. Or retroperitoneal retroperitoneal fibrosis, which again will cause a mechanical blockage of the ureter and stop the urine getting out and causes damage. Okay, let's move on. So this slide, what are the signs and symptoms of an acute kidney injury? So in the early stages, I think there are not specific signs that you'll see. Patients can present in many different ways, really. Some patients feel very unwell in terms of having nausea and vomiting. They may be confused, for example. Other patients won't be. Some people will complain of tummy pain, abdominal pain, or backache. Some patients might be edematous, but not all for sure. I think the thing to look out for here is the lack of urine output, and being aware of any of these other signs and symptoms that come alongside that reduced urine output will certainly be alerting you that you need to be doing a serum creatinine or a blood creatinine level to try and understand whether we're looking like we're heading towards an acute kidney injury. So I've said a couple of times really that the main two ways an acute kidney injury is identified is through the urine output and the serum or the blood creatinine level. Sometimes people talk about urea as well, but that hasn't proved in all the testing and the research to be as reliable as looking at the creatinine. So they're the two markers we look at, urine and creatinine. And that's what it really says on this slide, so we can move on from there. I suppose just to note, these are from a global recognised criteria, and they form part of the best practice guidelines. So there you go, it's not just me making it up today. So urine output. What is the minimum amount of urine that an individual should pass on an hourly basis? So I'm presuming most of you will be aware of this. We need to work on a basis that at a very minimum, we want to see at least 0.5 ml per kilogram of the patient's body weight every hour being produced. In health, we would usually produce at least 1 ml of urine, so twice as much. But in ill health, the minimum amount of urine we're going to accept is 0.5 ml per kilogram per hour, or half your body weight, as it says on the slide. So, for example, an 80 kilogram person should produce 40 mils of urine. 70 kilogram person, as it said there, would expect to produce 35 mils. And if you're in this situation where you are looking every hour at a patient's urine output and trying to determine if there's enough, you need to be asking yourself at the question at the bottom, what could be the possible causes of this reduced urine output? You will have all come across the block catheter, and sometimes that can be wishful thinking, can't it? You can guarantee you'd go and speak to a doctor about a patient's urine output, and that's one of the first things they'll ask you. I'm sure you will all at some point have come across a patient who's been sat on their catheter, or somehow it's been disconnected and that has been the problem. So you'll learn very quickly to check that isn't the cause of the situation that you're seeing. And unfortunately, 9 times out of 10, it isn't a catheter problem. It is what you're seeing is an AKI. So blood creatinine level, the other marker that we've found to be really important, is worth talking about for a few minutes. So creatinine is a chemical that's a waste product that's broken down just from normal muscle metabolism. It's transported through the bloodstream to the kidneys, and usually the kidneys will filter out most of the creatinine and get rid of it through your urine. But when the kidneys aren't working very well, the levels of creatinine in the blood rise because the kidney isn't getting rid of it effectively. So that's why it's really helpful for us to measure that so we can see how the kidney is functioning. So we can use the urine output and the serum or the blood creatinine to stage how severe or not severe the acute kidney injury might be. And you can see on this slide here we've got the stage 1, which is being called early AKI. A patient's got less than 0.5 ml per kilogram per hour of urine, for 6 hours going on. So let's say there are let's say they're a 60 kilogram patient. We would be wanting 30 mils of urine per hour, but actually we've only had 20, and that situation's gone on for 6 hours. So that would be looking at the urine part. We then look at the creatinine. So a relative creatinine rise is taking what the baseline was, so on the first bloods that or if we've got a baseline from a previous admission, and looking to see whether it's increased. So has it gone up by more than 1.5 from what it was? So if there was the creatinine 10 and now it's become 25, that would be a 1.5 increase. We can also look at an absolute creatinine, so what the actual creatinine level is if we haven't got the ability to look at what the previous one had been for that particular patient, and we're basically there just looking to see if the creatinine is more than 26. So as we move to a more moderate stage of AKI, the reduced urine output has been going on for longer, so for around 12 hours. And with that, we will see a 2- or 3-fold rise in the blood creatinine. So I can't remember what figures I've just told you, but yes, imagine if it had been 10, and then we're seeing it's risen to 30. That would be a relative rise. A severe AKI is stage 3. And that is when the patient has a reduced urine output of less than 0.5 mils per kilogram an hour for 24 hours, or if they haven't passed any urine at all for greater than 12 hours. We would see a greater than a 3-fold rise in the creatinine, so we see a great big jump, or we can see the absolute creatinine is over 350. So that can just give you an indication of where your patient's at, I suppose. I think it's really important to stress here that the earlier on in this staging process you identify and start treating the acute kidney injury, the much greater chance you have of turning that situation around for your patient and improving their chance of recovering from this AKI and reducing their mortality. I'm going to just put all of these little things up on the screen rather than let them come one by one. Okay. So developing a management plan for patients who might be showing signs of an AKI. So whether you've got the reduced urine output, the rise in creatinine, or both going on at the same time. The first thing to do is to screen and look for sepsis or low perfusion, so low blood pressure. The second thing is to try and avoid any toxins that are going to cause further damage, so that are going to add insult to injury. So we're going to look at the medication chart. We're going to reduce the amount or frequency of medication that could be nephrotoxic or damaging. We're going to have a look and see if the patient's had contrast recently, and certainly report that to the medical staff if that's become part of the problem, to see if there's anything we can do to help with that. So moving on, we would need to optimise the patient's blood pressure if we'd identified that the blood pressure was low. There's quite a few different ways we can score patients for this, but we hopefully all areas have moved over to the National Early Warning Scoring 2 system. So that would enable us to recognise the deteriorating patient and recognise somebody whose blood pressure is dropping and might have a low circulating volume. We're going to look at the urine output if we haven't already done that, and if we weren't able to measure urine output accurately at this point, we would be considering putting a catheter in. To treat the low blood pressure, we would give intravenous fluids, and this is a point where you would use a fluid challenge. So rather than increasing the maintenance rate a patient was on, you would give around 250 to 500 mils in a bolus quickly to try and lift the fluid levels up in the body, the circulating volume up. And that, I suppose, the caveat to that is whether the patient's got a degree of heart failure might affect whether you can do that as promptly as you might want to or not. But certainly it's not just increasing the maintenance fluids, it's generally trying to replace the lost volume. And you're going to consider withholding antihypertensive medication, so we're not pushing that blood pressure down when actually we want it to be coming up to help us reperfuse the kidney. The P part of the STOP acronym stands for preventing further harm, so trying to look for the specific cause of the AKI, and goes back to the illustration we looked at with pre, intrinsic and post-renal causes of acute kidney injury. We might also do urinalysis looking for infections or any other problems. So when the kidneys start failing, as you will have picked up on when you looked at the YouTube video by Emma Bryce, there are many different problems that occur in the body. One of those being the blood potassium levels rise, and that can be dangerous, can't it, because it interferes with the contractility of the heart. So we need to do something about that, and we might need to treat that complication. When the kidneys stop working as well, patients become acidotic, so acid builds up in the blood, and their ability to pick up the acidic elements like they normally would do in health are impaired. So we might need to treat acidosis. Patients can also become overloaded with fluid. If we're not releasing some of the fluid that we're putting in, we might see patients becoming pulmonary overloaded or peripherally overloaded. So pulmonary, you would see probably pulmonary edema. If it's peripheral, it would probably be over a longer period of time, and you would see swollen limbs, hands, that kind of thing. And to prevent further harm, the other thing we need to do is look at daily blood profiles to just check that we're not missing anything else that could be going on at the same time. So there's loads of different ways to try and remember the treatment. Some of you will just remember it because you've seen a patient and remember it. Some of you might find it useful to use STOP. I think it's just a way to be systematic and make sure you're considering everything you need to when you come across a patient who might have signs of an AKI. So just to finish up, I just wanted to mention a few resources that are there to help you with this. And I suppose, there are lots of different ways trusts are trying to protect patients from acute kidney injuries, but all of these things are fairly common, and I think you'll see in all areas. So the kind of resources you'll all be familiar with fluid monitoring charts. I'm sure you'll all be familiar with early warning scoring systems to let you spot the deteriorating patient. Most early warning scoring systems, certainly on News 2, will also have an escalation or a deteriorating patient pathway, what to do if you find a problem. So that's designed to help you with this, and certainly we should be applying the deteriorating patient work to patients with an acute kidney injury. That is, even if they're sat up talking to you, can breathe, they are still deteriorating. You might have come across intentional rounding, that purposeful look at patients, checking on their fluid status and their urine output and whether they're drinking, whether they've been turned. So that can come in here and can help us to protect patients from AKI. And other nursing care guidelines might have been designed in your area, so certain pathways that your patients are on might have been designed to try and support you to look after patients with acute kidney injuries. Other things we know are available within trust to manage patients. Things that come up, so care bundles. Some areas will have stickers in the notes to say, if you identify a patient with a low urine output, have you checked the blood pressure, have you considered a creatinine, have you reduced medication, for example, that tie it all together and make it easier for you to do the right thing, really. I mentioned at the beginning lab alerting systems. So when blood results pop up, sometimes you get a little pop-up that comes on the screen and says this patient potentially has an AKI, check patient, check bloods, check this, check that. So that can be a useful thing. I say that can be useful slightly in a concerned way, because sometimes we become numb to that kind of information, don't we? So if things keep popping up on the screen at us, we quickly become blind to it. So yeah, just bear that in mind. Then we've got specialist nurses teams who support us, so out of hours teams, advanced practitioners, outreach, who all will be interested in patients with potential AKIs, so get them involved. as well as the specialist nephrologists who are obviously very experienced and used to dealing with patients who are suffering from kidney problems. So that's been a whistle stop tour. I know screencasts can be hard, so I think we've been going for about half an hour now. They can be hard to listen to. So any questions, feel free to get in touch with anyone from the Consolidating Science module, and we will obviously try and help you to answer any questions that you might have, and try and catch up with you at some point on that. Thanks, bye.